Good morning, everyone. Thank you for taking your precious time from your tight schedules to be here. I'm Dr. Kai Hsiang from the Department of Radiology in Tri-Service General Hospital. I'm currently a newbie attending physician majoring in neuroradiology. And today I would like to share with you my personal experience using a cervical epidural block patch to treat spinal CSF leaks in patients with spontaneous intracranial hypertension. Later in the speech, I will use SIH for abbreviation. So what exactly is a SIH? It's a medical condition caused by CSF leakage, almost always somewhere along the neuraxis, most likely the spinal axis. The common causes including a meningeal diverticular, nerve roots avulsion, dural tears, iatrogenic procedures, and dural venous fistula. Clinically, these patients often present with a classic orthostatic headache, which worsens when upright and improves when lying down. Some also develop cranial nerve palsies, causing a visual or hearing disturbances, or even encephalopathy with rapid cognitive decline. And in more chronic or severe cases, you may see complications like subdural hematoma, CVST or FBSS, stands for a frontotemporal brain sagging syndrome, mimicking behavioral variant of frontotemporal lobar degeneration. Typically, the leak occur most often in the thoracic region, followed by cervical and lumbar spine. And according to the ICHD-3 classification, diagnostic criteria for low CSF headache requires either a measured low CSF pressure below 60 or image evidence of a leak, and that the headache developed in a temporal relation to the leak. Importantly, we must exclude other causes of secondary headache. So both clinical correlation and image confirmation is essential to make certain diagnosis. And here is another interesting physiological concept is called a hydrostatic indifference point. It's a level along the neuraxis where the CSF pressure remains constant, and it's roughly at the lower cervical and the upper thoracic region. Okay, and the skull base, the CSF pressure is slightly negative. So this helps to explain why skull-based dural tear does not necessarily cause symptoms of SIH. And here is a beautiful annotated illustration tells us the crucial anatomy of structures of the spine. The epidural space contains here is the dorsal and the ventral epidural space. It contains semi-liquid adipose tissue and the spinal venous plexus. And the ligamentum flavum is a very important anatomic landmark right here, just attaching to the dorsal dura. And notably, here is the sympathetic trunk, which is responsible for some complications such as a transient autonomic dysfunction after blood patch. It's located anterolaterally to the exciting roots. Here is an image example. We can see the ventral dura is outlined by abnormal CSF collection in the ventral epidural space here. And the ventral root and dorsal root, they meet at the lateral recess of arachnoid space here at root sleeve and join each other confluence in forming a exiting root. So any CSF beyond this point is considered abnormal. Now let's jump to brain MRI features for SIH. Typically, you may see a pachymeningeal enhancement and a venous distension sign, which can be explained by the Monro-Kelly hypothesis. I believe everyone is very familiar with. It's stating that a static intracranial volume comprises basically three elements, including a brain tissue, followed by CSF and blood. So in spinal CSF leak, the CSF is depleted, so the venous blood become more prominent in our brain tissue, so increase cerebral blood flow. You can also observe some patient present with a chronic subdural hematoma or hygroma. And you can see a plump morphology of pituitary gland due to venous congestion. And in the CT, you may see a cake layer skull, which represents a diffuse calvario hyperostosis. The main differential diagnosis, hyperostosis frontalis interna, which only involves the frontal skull. and single layer with a scalloping of the inner table of frontal skull. And some patient, you can see, acquired tonsillar ectopia due to a brain sagging syndrome. Here is our case. 帮我播一下可以吗？ Can you press the play button? It's a video. Okay. Here is our case of, it is our case presenting to ER due to a bilateral spontaneous SDH, which manifests as the first and only symptoms for SIH. In such cases, emergent surgical decompression is mandatory. And based on prior research, EBP should be performed before the epidural surgical decompression. And also, we have some quantitative measurement, including a mammallopunting distance lower than 6.5 millimeter, and a puntum mesencephalic angle lower than 50, interpeduncular angle lower than 40. So when it comes to localizing the leak, MR myelography is often my personal first choice. Okay, we perform a high-resolution 3D isotropic T2 weight image called SPACE, VISTA, or CUBA by brand name, and a single slice MR myelography, which allow us to visualize the leak at one glance. And I will perform a whole spine sagittal T2 weighted image for spinal labeling and correlation. And the last one is optional. You can perform a multi-planar T1 or T2 by your preference to evaluate those brain structures. Here is an example showing that the spinal CSF leaks at one glance. You can see all the leaks. And on the right-hand side is the sagittal T2 weight image for level labeling. Here is an example of CSF leak. 帮我播一下. Play the play button. On the no 上一张再上一张下一张那个是一个影片档，左边是影片档。你们把那个雷射笔关掉好了。雷射笔关掉，然后那是一个影片档。上一张，这是一个影片档。Okay, on the left-hand side is a case, is an example of CSF leakage. As you can see, there are circumferential CSF collection around the spinal cord. And on the red dotted annotation here represents a dorsal CSF collection here. And it separates the dorsal dura and ligamentum flavum by the CSF collection. And here is the ventral CSF collection here and displays the ventral dura posteriorly. Here's another case that on the left-hand side is a normal MR myelography. The CSF does not exceed the root sleeve. On the right-hand side, however, you can see a periradicular CSF leak at the C7T1 level. So when MRI fails to pinpoint the leakage site, we often turn to a CT myelography, which is my second line, because it's a little bit more aggressive. You have to do the lumbar puncture. You have to inject the intrathecal contrast median. So on the left-hand side, you can see the orange arrow points out a ventral CSF collection outlining the ventral dura. Okay, on the right-hand side of the screen, you can see a small periradicular CSF collection. There is a contrast extravasation at T9 level, which is very small and very subtle to see on the MR myelography. So we need a CT myelography to confirm our diagnosis. Now let's turn to the technical consideration. In our center, we performed the procedure with the patient prone and the neck slightly flexed. We used a 2 to 3 millimeter slice at the target level and approach to near the spinal cord with a paramedian or midline interlaminar approach and inject up to 30 milliliter of autologous blood mixed with contrast medium. There are also some peri-procedural considerations you must think about. The first one is how to prevent the clot from clot forming before injection, and secondly, to know the exact location of your needle tip. This is our settings. As you can see, it's very simple. The only thing you need is a 25 milliliter syringe connected to a three-way switch, a connecting tube, local anesthesia, and contrast medium that is indicated for a mammography. In our hospital, we use an Omnipec 300. Our leading role is a 22 gauge spinal needle. And on the left side is a tube shaker. This device is a prototype. 帮我再播一下，下面这个，这是一个影片档。Okay, this is the prototype of a blood shaking machine, which is invented by our amazing team. I will show you in the next slide. We got a patent certificate. Of course, you can see Dr. Xi right in this picture. He is a very endearing tutor of me. And here we won a national prize, and this is the illustration of the prototype. Next, how do we exactly know where the needle tip is? Okay, this illustration comes from a published published paper, also by our team. We look for a triangular fatty plan over the dorsal epidural space, just beneath the ligamentum flavum. And once you think you reach the dorsal epidural space, you can test injecting small amount of contrast to see if the contrast is connected to the needle tip. If that's all, if it is, then I will personally inject more contrast, about 0.5 milliliter, to see if there is any boomerang-shaped contrast morphology. Now let's talk about the safety. Safety is an important issue in any kind of intervention, and cervical epidural blood patch makes no exception. With a controlled injection of blood patch and a careful intra-procedural evaluation, we can evaluate the patching distribution. Is there any mass effect compressing the cervical cord? And in post-procedural monitoring, I personally routinely perform a whole spine CT for a final distribution evaluation and predict the outcome. Here are some reported clinical outcomes by Kapoor and his colleagues. They reported a 19 patient with 100% long-term symptom resolution without major complications. And the reported success rate ranged from 80 to 100% when the leak is precisely targeted. But notably, some of these patients received a failed prior lumbar EBP, so they are not treatment naive, okay? In our institution, we have performed over 200 cases, 200 procedures with a total of 150 patients. All of these patients receive a targeted EBP. Our success rate is quite amazing, okay? 129 patients reach complete symptom-free by a single EBP. 15 patients requires a second consecutive EBP. Only 9 patients required more than 3 times treatment. And the average extension segment in our group is about 14.75 segments. In other published literature, in cervical region is around 3 to 4 segments. So it's pretty amazing. The average injecting volume is around 27 milliliter. Okay, let's move on to our cases. This is a 41-year-old female teacher who experienced an orthostatic headache with dizziness and vomiting for the past 2 months. She also complained of blurred vision and memory impairment. In the pre-procedural CT, there is a conspicuous hypodensity in the left thalamus, which is pretty alarming to me because I was afraid the neurologist will mistake a acute ischemic stroke for SIH. So I ordered an MRI. 请播放，帮我播放。 And here is the DW of the brain, which shows a striking posterior circulation ischemic stroke, which is relatively very uncommon and rare complications of SIH. Of course, the MR myelography showed a periradical leak at cervicothoracic junction. Then I performed a targeted EBP at the C71 level with a midline interspinous interlaminar injection with a total of 25 milliliter of blood patch. The patient experienced a provocative headache, neck stiffness, left radicular pain during the procedure, but the symptoms completely resolved after 12 hours post-CEBP. And this is the second case. He's a 75-year-old male neurosurgeon. Happens to be colleagues, my teacher in the hospital. And he experienced a headache, gait disturbance, and dizziness with a rapid cognitive impairment complained by his colleagues and his family. And there was no history of trauma. And the CT on arrival can see shocking bilateral spontaneous mixed stage SDH. The MR myelography later confirmed a multi-level periradicular CSF leak at cervicothoracic junction. So I performed a targeted EBP at T1, T2 level with a part midline interspinous injection of 31 milliliter of blood patch. And the patient received a subsequent decompression craniostomy immediately after CBP. These are the follow-up image in 1 month and 2 month 请播放 play. This is a 1 month after CEBP. On the right hand side is a 2 month. Okay. As you can see, the subdural hematoma regressed quite remarkably. Okay. And this is a very touching moment for me because it's not every day you can receive a thank card from your teacher. And lumbar versus cervical EBP. The lumbar EBP, so why cervical? Okay, lumbar EBP is often performed blindly with a reported success rate between 60 to 70%. Okay, and the pen score reduction by 8.7 to 3.5. So the advantage of lumbar EBP is theoretically lower complications with a larger epidural space, and the proximity to the spinal cord is less likely an issue. But the disadvantage, it's less effective when the leaks are more rostral and multi-level, and when the CSF leaks is recurrent. So let's talk about cervical EBP. It's performed targeted in all cases with a better outcome and rapid symptom relief. It requires less blood patch volume, smaller cervical epidural space, and its proximity to critical neural structures. And in my opinion, it can reach a wider patch extension due to the gradual increase of the capacity of epidural space from C to L spine. But the disadvantage is also very obvious. It has a higher rate of discomfort with provoked headache, radicular pain, cranial nerve symptoms. But luckily, these are just transient and it resolved on its own within a few hours. And it relatively lacking a large randomized control trial, only small cohort. The last, we talk about the possible complications of EBP, including a spinal cord injury, intradural injection, infection, transient paresthesia by the mass effect, and transient autonomic dysfunction, which imitating a neurogenic shock. Okay, and on the right-hand side is a case, in my early cases, I incidentally inject all the blood patch into the intrathecal injection. But luckily, the patient experienced no complication, but a mild headache. But it can cause a septic meningitis, so it's very crucial to know about. And talk about the infection. You have to confirm that the patient is not systematically infected or sepsis or something, and there is no systematic cancer or any known malignancy, or it may cause a leptomeningeal carcinomatosis. So to sum up, the cervical epidural blood patch is effective for high cervical leaks in SIH, and careful image guidance is essential for precision and safety. with appropriate technique can minimize all the complication and risk. Thank you for your attention.